we're delighted to have the Healthcode team here with Peter Connor and Fiona Booth. And so this seminar follows our recent one with Keith Haig, in which we were sort of really talking about the situation at the sort of the nadir of the pandemic, and we've just done the LCA survey. And it was following on from that, that there was some data appearing from Healthcode, which was looking at private practice activity, which is what has prompted today's meeting. And so a lot of us have, and I've said this to Peter last week, I've had the pain of trying to register with Healthcode. I don't know if any one of you has tried to do that recently. It feels like one of my major degrees, actually. I've got Healthcode now added to my letterhead as an achievement. And I actually put it on my CPD at the end. So Peter and Fiona have very kindly agreed to speak about Healthcode. And so I was just going to start actually by asking Peter what his background was, how he's got into the healthcare market, and indeed how Healthcode has sort of taken over the invoicing market, as it were, and how it's sort of been established as a business. So thank you very much, Peter, and welcome.
Thank you, Mark, and I'm sorry to hear of your pain, but we will we'll do everything we can going forward to ease the pain. Believe me, we're aware of some of those pinch points. But that's always a great way to introduce things. So thank you. I've actually been with Healthcode for 18 years now, and Healthcode itself has been, I think we were due to have a 20th birthday party this year, but for obvious reasons it's been that's been deferred. But Healthcode existed obviously before my time, and it also existed in a previous incarnation, and I believe it goes back to when Bupa had hospitals. There were the Bupa hospitals and Bupa insurance, and there was a department within Bupa where the Bupa hospitals built the Bupa insurance company. And then I believe a joint venture came between Bupa and PPP, as they were then, to extend that, and a company was formed called Data Health. Data Health lasted a few years and turned into Healthcode. So Healthcode's been going about 20 years. It was set up primarily as a billing organisation to process private medical insured medical bills. And that's still largely what we do. But as I'm sure you can appreciate, there's only so far you can take that, and after a while it tends to get a bit boring, so you want to do more things. But that still is our core business. And I've got some data that I'll follow up when we get onto some slides that will show you what those activities are. But the company's been, as I say, in existence for 20 years, doing that sort of thing. I joined in 2002. I was actually a .com victim. I was in telecoms before, and I was one of these telecoms millionaires who left with nothing. And I took the job at Healthcode as an interim step when they needed an IT manager. And I saw a disastrous company, which I wanted to get out of as soon as I could. But instead, I stayed there, and I've been there ever since. And I became MD in 2011. So, but as I say, my background was more to do with technology and telecoms, and actually before that I was in oil and gas and hospitality industries, hotels. So I don't have a medical background. It was a technology and project management type background, but I've been with the Healthcode now for 18 years. So hopefully I've felt my way around and
although I did tease you a little bit regarding the application process, many of us will remember the previous process where we had to submit individual invoices by post to Bupa. So I think there's been a massive change in terms of how we've operated our business. So we talked a little bit last week about that obviously you've captured this sort of data that no other real part of the industry can, and I was just interested, going back a bit pre-pandemic to sort of the January time, what your view at that point was of the private practice market in terms of optimism, development, and whether you felt it was a really big growing business at that time.
To be honest, it was fairly encouraging. If you don't mind, I'm going to just show you a slide at this stage. So Healthcode's market share in terms of billing hospitals is not far off 100%. We are fully ingrained in hospital billing. So all the private medical insurers and payers use us, and pretty much every private hospital uses us to bill. So we are pretty much a monopoly player in that sense. And therefore, our sort of hospital billing volumes are a really good barometer of the sector. And you can see sort of from 2015 to 2018, we had a very flat sector. In fact, in 2017, we actually had a slight reduction in overall volumes. But last year, well, 2018 to 19, we actually saw a 3% increase for the first time ever. So we were actually quite optimistic because, as I say, we are quite a barometer. We don't lose any customers and we don't gain any customers in this part of our business, simply because there aren't actually any to lose or gain. So we had actually seen a 3% growth in the hospital market from 18 to 19, and we're quite optimistic, I must say, on the private sector.
Just to clarify, Peter, this is the
early 20.
Sorry, so just to clarify, this is the insured sector, which we estimate was about 50% of the market, with 30% self-pay and 20% overseas. So that 50% you don't get involved with. Is that how you how you understood it?
Yeah. Since we last spoke, Mark, I did a little bit more analysis on this, and we actually think it's about, for London anyway, we think it's about 60-20-20, and then a 1. And I know that adds up to 101%, but I just wanted to make the numbers easier. It's about 60% PMI, 20% self-pay, 20% embassy/overseas, and then a little residual 1% on the NHS side is what we were seeing before that. So we think this is probably representative of about 60% of the London market from what we see.
Okay, good. Just I'll pause there for a second. Has anybody got any questions so far, looking more historically, before we move on to what's happened post-pandemic? And is that relatively clear?
Can you just clarify, those bills are relating only to substantive inpatient episodes, or do they cover physio, etc.?
No, it's inpatient and outpatient, so it's anything that we see through hospital. So again, sorry if I'm going to chuck stats out, but in terms of those volumes, about 80% of it will be outpatient, about 15% will be day case admitted, and 5% will be inpatient admitted. It really is that simple to remember those numbers, actually. 80, 15, 5 from what we see as a breakdown. So 80% of that activity is outpatient.
Okay.
But it's all through hospital-based episodes. Unfortunately, for the consultant market and for the practitioner market, we can't really give you as great an assessment because we don't have the same market coverage. So our growth on the, if you say the non-hospital side, so the practitioner side, consultants and smaller clinics, has been quite rapid. You can see on that slide, but that's more to do with us acquiring customers. Obviously, the market growth, our market penetration has not been anywhere near as high on the non-hospital side as it did on the hospital side. We think we're somewhere between 65 and 70% of the practitioner and healthcare market. So we process more invoices now for practitioners than we do for hospitals, but we're not up to that sort of same level of market penetration where we can accurately give a confident benchmark, if you like, because this is to do with us gaining customers and gaining volume.
Okay, any other thoughts or questions at this point? If not, so Peter, so the pandemic happened, and there was obviously a bit of a dip, I think, leading up. I think most of us noted in the week or two prior to the lockdown, things were quietening already a little bit, and then we had a very quiet April and May, and so it was sort of June, July time. Healthcode started publishing data showing how the situation was recovering. So do you want to just talk us through how your view of that period was?
Yeah, absolutely. I think let me just flick forward. Sorry, I'm a little bit random here, but I'll show you. This is only a snapshot of the volumes of 2019 versus 2020, but it gives a good indication of where the gaps were. And you're right, the first week in May was the lowest. We saw the low point in terms of, so the green bars, I should say, I beg your pardon, are 2019 volumes, and the blue bars are 2020 volumes for the same period. So it did go to a low point of about 20-25%, and that was the first week in May of where it went to. So we had a fairly rapid decline. Unfortunately, when I put the graph out too wide, it looked a bit squashed. So I thought I'd pick on the lowest point and just highlight that point. So the low point, as I say, was the start of May, and it's now recovered. In fact, on the last week of August, we actually processed as many invoices for that last week in August as we did in 2020 as we did in 2019, although I think that's a little bit misleading. I don't think it has fully recovered. But we started to see, as I say, a very, very gradual recovery, but nonetheless a sustained recovery from the low point in the first week of May. And
is that, may I ask a question? Sorry.
Yeah, of course.
Is that national, or was that once again London centric? What?
This is a national picture. This is a national picture. Yeah. It's very interesting. We've seen massive differences in recovery from three parameters. Firstly, geographical. Some areas have recovered incredibly quickly, other areas very slowly based on geography. Then specialty as well. In fact, some specialties are actually above. Oncology, for example, is above the levels for 2019 for us at the moment. I'll show you a specialty-based recovery slide, but we've seen massive variations by specialty. And then, potentially slightly controversially, hospital groups. We're seeing massive differences between the hospital groups. So every month I send the CEOs of the big 6 hospital groups their current recovery status versus the sector. There are big differences between how the groups themselves have recovered, and I'm not in a position to interpret that. I don't know if it's because of the way they run their businesses, or their various specialty mixes, or their geographies, but there have been very, very pronounced differences in that recovery. It's not a consistent picture, and it's quite interesting because I've had a fair bit of kickback and feedback saying, well, you know, I've still got no patients, or the hospital car parks are empty, and I can see that, and I can accept that because it's a very varied picture across those 3 parameters. We picked a random, in all honesty, just a random set of specialties here, just to show the recovery. And there's 3 months. There's June, July, August, and then there's A and O, and A is admitted, so in other words, admitted inpatient and day case procedures, and then O is the outpatient. And this again is looking very much at London, but you can see by the specialties some of the differences. So, I mean, ENT was interesting. I think I picked that one because of, obviously, for a COVID perspective, so that's the second chart. You'd expect ear, nose and throat to potentially be not areas you'd want to go in the middle of a respiratory pandemic. And you can see in June, for example, it was 8% of admitted cases compared with this time last year. That's now recovered up to 46%, but there's still less than half of the ENT admitted cases going on. Whereas, you know, other sides have increased significantly more. We included orthopedics as well, because orthopedics is obviously the volume side of private practice usually, and that's our biggest specialty area by volume. And again, that really has only just recovered to about 2/3 of where it was. Whereas surprisingly, for example, general surgery in London last month for the private sector was at 91% of where it was this time last year. So you can see, you know, other sides have increased significantly more. We included orthopedics as well, because there are significant variations, but that's a London view by specialty. As I say, we just picked a random sample for the point of today, just to show you how those are.
And just to say, Peter, what was interesting was that I didn't realise that inpatient work was so little of the total, in the sense that of the total amount of private practice, 5% you mentioned, I think, was inpatient work. And our perception, I think, is that there's a lot more inpatients going on. So, of course, if you're looking, because I think when one hears, not exactly criticism, but observations about your data, of course, it's the surgeons who are struggling to get patients admitted. That's the issue at the moment, more notably than anything else. And of course, being a relatively small percentage, even if that was 1 or 2%, it's not going to make a massive difference to your data set, is it?
Potentially not. I am reporting here volumes rather than values.
Okay.
So, and obviously a patient journey, a patient episode will have a whole series of billable events, one of which may turn into an admitted procedural event. But obviously, the majority of patients are not admitted, and that will include all the diagnostic activity that leads up to that. So I am talking, you're absolutely right, about a volume rather than a value related benchmark here.
Because the other thing we discussed is whether sort of the August month was the catch up from everyone who hadn't been in May, June and July, of course, that there was that big group of people that you saw as an outpatient. So that probably, and also I suspect a lot less people went away in August than usual. So there probably were a couple of other factors around that enhanced that activity number.
It's interesting because we are talking obviously closely to the insurers who are also wanting to monitor how they see the volume recoveries come. And the insurers are pretty much pre-authorising or authorising the same amount of treatments now as they were this time last year. So they're back up to 100%. But when we discuss with them, you know, there's a big suspicion that a lot of that is residual and catch-up work, as you said, rather than actually a true reflection of the recovery. So, you know, there's damn lies and statistics, and these numbers I can honestly back up are being 100% correct. Every one of them is a patient transaction. However, I appreciate there are factors behind it. And I think, to be honest, we don't really know. I mean, I was talking to one of the big insurers on this just yesterday, and we don't really know just how much of it is catch up versus how much of it is general, back to, if you like, what business as usual was.
You mentioned oncology was very strong throughout, as you might expect. What percentage of the total sort of healthcare events are oncology based that you would define as oncology?
I don't know the answer to that off the top of my head, but I will definitely come back.
No, I mean, I didn't know whether
I'm not sure, to be honest, Mark. I'd be guessing, but
because it'd be interesting, because that seemed to have been very consistent throughout as a specialty that was maintaining activity level. Ellis, I mean, does this fit with your sort of perception of?
Yeah, I mean, I think certainly when you put this slide up, I think everybody, if your specialty is on there, you immediately home in at that part of the graph. And I would say, in my experience, I mean, you're looking at gynecology activity, you know, 80, 90% back. Personally, I think that's a slight over-optimistic. And my experience in talking to colleagues, most of us think we're probably between 65 and 75% back, but definitely moving in the right direction. And I think there's a clear, consistent trend across the way. Peter, I was going to ask you, I don't know if you're going to show your next slide looking at the activity by different hospital groups. You mentioned when you sent it through that half the chief execs were happy and half weren't. You're not collecting any NHS activity in private hospitals. So it may be that some of those groups that have got less PMI work are actually have significant clinical activity and revenues from NHS work. But I don't think you can actually capture that, can you?
No, you're absolutely correct. This is all private patients funded by private medical insurers. You're absolutely right. So, yes, we don't have that visibility of the NHS funded work. You're right.
Yeah.
Just, I mean, I appreciate these figures are prone to scrutiny, and you said they may be optimistic, but equally, as I said, they are backed up by an actual transaction between each one. So again, you know, there could be variations, but those are scientifically calculated. They're not projections in any way.
The data is the data.
When we spoke before about coming into this session, you're asking me about sort of fees and how fees looked.
Yeah.
And so we did a little bit of analysis that I want to show to you. And again, this is probably quite sensitive, but I'd like to share it with the group to see if it's of interest. We just looked at some of the fees that have been charged just by initial consultations by practitioners so this is looking at actual fees charged for initial consultations for the last 6 months of last year. So again, we've picked some random specialties, but the first one we'll pick, for example, is orthopedics, and this is we've banded it effectively into £25 increments. But if you're interested in what sort of fees are charged for PMIs, then 37% charge for initial consultation between 125 and 150 band. Then there's a dip, 26% in the 225 band. And you've got that sort of range. So those are the sort of fees, for example, that we see for orthopedics. If I then looked, for example, for dermatology, you'll see the dominant range being in the 175 to £200 mark, and more of a sort of traditional histogram type presentation. And then I sort of thought I'd play to the audience. Might be interesting to you, Mark.
Yeah.
To look at endocrinology. So again,
It's good to know I'm in the lower 5%, Peter.
So, and then just as an example, oncology, you'll get a higher type approach. So I just thought, you know, because you'd mentioned sort of what sort of analysis on fees and what sort of thoughts on fees by specialty were, that's a consolidated view of them. You might wanted to be interested to see what sort of things are being charged.
And of course, some of these fees are agreed for the newer consultants by the PMIs as a sort of a condition of being taken up, aren't they, of course?
It's total aggregate. It's not, I've literally just gone by specialty.
No, it's very,
so there's no sort of length of experience, there's no geographical basis, but these are fees charged. Rosemary, down to get in.
I mean, this is just a reflection of how successful the PMIs have been at fee capping in the different specialties, isn't it? I mean, it's not a true reflection. It's just a reflection of how which specialties they've managed to control the best, to put it crudely.
As I say, I picked 4 random ones.
Yeah, okay. Interesting stuff though, Peter.
Yeah.
Can I just say, Mark, that in all the studies we did, and there have been several of them for the CMA, the major fee factor, apart from the insurer, was geography. And you know, there's a marked difference you can go by, especially you can do anything. And whatever it is, if you're in South Wales, it's different to South London, etc., etc.
So that's a good point. I mean, I think this is a sort of data that's, you know, you can see why, you know, Healthcode have got almost a unique data set in terms of looking at these various factors. On those sort of, you mentioned, we talked a little bit, Peter, about the PMI changes and how you quoted to me, and you've been using this phrase all week, the yield management model. Do you want to just explain to me again what you meant by that and how the PMI changes how the PMI may change over the coming years?
Yeah, I think there were 2 different things, to be honest, Mark. But I mean, in PMI, I mean, I'll take charts down in a second, but there was one other that I wanted to show you. If we just look at market shares, this is a real current snapshot of what we're seeing. And to be honest, when we did it, it surprised me because I must admit I was always under the impression that AXA was closer to Bupa than they're almost neck and neck. But from what we're seeing now, Bupa is still significantly dominant. So there's 40% is Bupa, 33 AXA, 10% Aviva, and 7 Vitality. And if you add all those up, then the those top 4 are 90% of the market. So that is a share based on transactions and activities rather than anything that anyone may wish to report externally. But I think in some of the discussions, and it tends to be the smaller insurers, but I think it's happening with the bigger ones as well, is there seems to be more of a move towards healthcare trust business rather than actually the old traditional PMI. And some of those trusts do tend to get sort of hidden away when they're covered by the bigger PMIs, but in the smaller ones, I think there are much more flexible funding models that we're seeing coming up that are more trust-based rather than PMI. And I think that's sort of been quite interesting through the pandemic stage as well, because obviously a lot of the PMIs have come under criticism, which we can argue whether it's fair or not fair. I personally think they've been, I'm not always the biggest fan of PMIs, but I think in this side, they've been a little unfairly bashed. But the PMI original, you almost say you've got to sort of use it or lose it with your policy. If you don't claim on your policy, then your benefit goes. Whereas obviously, if there's a trust market and a trust fund, then whatever is not spent in the trust fund gets carried across. And we're seeing a lot more trust type business, and it does tend to get pushed by the smaller PMIs. But you know, if there is anything to shake up this market, we are seeing more moves towards trusts, and that obviously gives corporates the capability to give a much more flexible benefits program as well. So not only do they not potentially risk on losing their fund, but they can have much more flexible benefit packages than I think traditional BMI will be. I think it's small changes yet, but in all honesty, if there's any sort of major change to the funding model, that's pretty much all we're seeing, because the dominant ones are still the same. I think the yield management point was more to do with actually filling up spare capacity. And you know, I think historically, obviously, the hospitals have used the spare capacity to fill up with NHS patients. And I think we were more sort of talking towards that point. But obviously, the second NHS contract is still, from what we see in the second NHS contract, what we hear from the commercial directors from the hospital groups is they're optimistic they will not be impacted too much in terms of their ability to admit private patients, but what you read in the press feels somewhat different.
The other factor that sort of crops up, as a physician, this doesn't really affect us so much, is this sort of class coding and classification and how the reimbursements are made, particularly for surgical procedures, and the difference between the NHS and the private data and how that's classified. Do you want to just give us an overview of the difficulty in that area and how that may play a role in the next year or two, where you see that's going?
Yeah, so I think this is probably, is this the difference between the CCSD and the OPCS coding? Yeah. I mean, obviously, it's interesting because one of the things that we are going to be introducing very soon for all consultants who've got your certificate, Mark, who've passed the test and have got access to the private practice register, is a scope of practice indicator, which will play back to yourselves exactly what you've done, where you've done, and what sort of volumes you've done it at. And what we're trying to do with Fiona is to amalgamate that with the NHS data. And it's a bit of a ball's ache, sorry to say, trying to get access to NHS data, but we are struggling away with the legal process and hopefully making progress. But it's very difficult to compare, obviously, activity in the private sector with activity in the NHS because they're coded differently. The NHS uses a system or a coding scheme called OPCS, and the private sector uses a classification called CCSD. And the two just do not match. In fact, we had an NHS clinical coder try and do the mapping for us, and there's about there's 45% of the codes there is a one-to-one relationship, and therefore 55% there isn't. So I think in terms of a lot of the reporting that comes out, and I know Finn struggle with this as well, because they ask all the hospitals to record and publish OPCS-based coding. They do that naturally because that's the coding system that the NHS publishes. But it is a challenge to map the two. And as I say, I think the two are largely incompatible. But in all honesty, in the last 10 years, every year there've been discussions about whether we converge the two, and every year, no, it's too complicated. They'll stay disparate. So I can't actually see it changing anytime soon.
I mean, it's funny because Finn were in the news this morning about this never events and capturing data versus in the hospitals in the private sector, and how that can be sort of called a sort of frequency per hospital event, as it were, and sort of relating that to the quality of the hospital. I mean, do you have a relationship with Finn? I mean, do you sort of share data with them? How
No.
does that work? No.
No. Historically, we used to capture all the admitted care data for Finn, and we would capture it for them and pass it to them for their publication and processing. But they do that themselves now, so we don't actually have any current data sharing. We are discussing with them and looking at areas where we could collaborate, but there's nothing active, no. So any data that we capture does not go to Finn.
Okay, and just, I mean, in terms of Healthcode, in terms of your future, as it were, I mean, are you going to go off into the quality agenda at all, or is it purely going to remain financial? Is there any sort of prospect that this data can be used to get quality?
I don't see us going into quality indicators, to be honest, because I think that's Finn's domain. And you know, they've been set up with that purpose, and that's their task. So I can't honestly see us going into that area. If I just this is the final slide, but I thought this may come up. So I mean, our future is looking at sort of, I think, 5 main areas, and it's not because of my audience, but genuinely, Healthcode's future we see very much aimed at serving practitioners, and that's partly because in many ways, as I say, with electronic billing, there's only so far you can go with it. Equally, we know we need to make it better, and you know, we can improve it. We know areas where we can improvement. So the sort of 5 main areas which we want to go into, and one is the private practice register, which is primarily set up for recognition and governance perspectives. That's fully established now with the insurers, but not fully with the hospitals yet, but we're working to roll it out through the hospitals. But what the private practice register actually does as well, and it's not being used effectively in this sense, is it gives the directory of service. It says who does what, where, for whom. And we want to sort of work with the industry to sort of try and, in all honesty, promote the accessibility of the industry. I'm about to get on my soapbox, but I'll leave it a little bit. But I still feel that our private sector is very difficult as a consumer to access, and we should be trying to introduce tools and modernise the way we do things, which I'll come on to in a second. But this private practice register is a massive database of who does what, where, for whom, and it's got profiles. And so we should be able to use that. We should be able to exploit that better. And it's one of the things I wanted to raise with you today, but I'll come on through the bullet points first. Practice management. We've got a very arrogant and ambitious goal to be the first choice, if you like, practice management system. That's our biggest area of development at the moment. We want to offer the best practice management system that's available in the sector. And also, I hope I don't sound too crass and corny here, at the best price as well. We believe that we can offer a better system at a lower price than consultants currently have to pay for practice management system. We also want to do more and more with affiliate programs as well. I mean, we do have 22,000 active practitioner users for our systems at the moment. We should be doing more with them. So we're about to launch, in fact, we're trialing it now, a medical indemnity insurance quote system, which will allow consultants to get quotes for medical indemnity insurance, quotes pretty much like that, very quick quotes, because I think that's an area where there's been a lot of criticism for effectively nothing ever changed, and the process feels rather unfair in terms of the way the premiums, or not premiums, I'm sorry, the fees are calculated. They're not data driven, so we are working, and we're about to become public about more data driven type processes, which we hope will allow more competitive pricing in that area. We've also got active.
Can I just ask Peter, are you acting as a broker with this for different indemnity companies, or are you going to offer your own product?
No, we're not going to offer a product. No. In fact, we're not even acting as a broker. What we can do is we can use the data that we've got, and that's either historic data or transactional data, to feed insurers or defence organisations with a data-driven approach, which we think will give we believe should give a lower cost and a fairer cost activity, a more activity-based costing for indemnity. We're still under NDA with a couple of the defence organisations, but we're talking to them about hopefully new products, and we're about to launch one with a commercial insurer, just to sort of try and modernise that market. And to be fair to the MDOs, I mean, we're under NDA, sorry, with two of them, and I think they are aware that this market needs a bit of a kick in the teeth, so to speak. So we're not going to be, I mean, Healthcode, I'm sorry to say it's frustrating for me in some ways, but I think it's absolutely right. We are absolutely agnostic, and we sit on the fence. We're not going to favour one over the other. We will not be exclusive to anyone. But if someone wants to come along with a data-driven indemnity product, or more competitive indemnity products that allow transactionally and risk-based information that's driven by data, then we'll help them do it. So, as I say, we've got a commercial insurance one launching soon, and we're under NDAs with two of the defence organisations, and we hope we can work with them. Again, I think one of the issues with private practice, there's so many issues with private practice, but one of them is the barriers to entry. It's so expensive to get in, and if there are data-driven ways to ease that, then Healthcode we're entirely a private practice organisation, so we benefit from the sector growing in the same way as you do as well. So the more we can do in that is the better. And we've also got an online payment collections system as well, with a company called Patient Zone that's being piloted now, that allows online collections. Again, I've got personal experience with this. I won't mention the consultant, but I saw a great consultant just ahead of lockdown. He sent an invoice for £200, £150 of that was shortfalls, of course. I got his shortfall letter 6 weeks after I saw him, and I had to either send a check or raise a backs payment. I mean, what's that about? There's pressure on fees as it is, but if you don't collect your money for 6 weeks and then make it difficult for the consumer to pay, then you're not helping yourself in any way. Sorry, that's a little bit aggressive, but I think there are ways that I think the whole market needs to modernise, and that's one of them. The other one is online video consultations. This is a Me Too thing, so this is nothing special for Healthcode, but what we're doing is completely independent. We're about to launch a tool for consultants to use that doesn't mean that you have to sign up to any scheme. It's completely independent, but allows secure online video consultations. So that's going to come very shortly. And then the big one, I think, is online appointment booking. My biggest personal beef with the private sector is the inability to book an appointment and to find consultants. to find hospital groups, and I get very angry with the sector, thinking that there are some sort of super brands or big brands here. There's only one brand that I can really think of in private healthcare, which is Bupa. I don't think anybody's heard of anything else. But if you go into other markets and you want to book a hotel, for example, you know, you'll go onto Expedia, you'll go onto Trivago, you'll go onto hotels.com, you'll find it there. And there's nothing that our private sector allows or offers that allows that to happen today. So again, I think that's part of where we're trying to help. I mean, we're not going to be the brand. I'm not saying the brand will be Healthcode, but we want to put in place the systems and the capabilities that will allow everybody to do that sort of thing. So our future is not, I'm not saying it's not electronic billing, that's not true. We want to support electronic billing. Electronic billing is fundamental to what we do, but we think it's time to do a lot more around that. And to be honest, sounds a little bit arrogant, but I think this sector is in dire need of modernisation and a better consumer focus, and that's sort of what we're trying to make our vision and our strategy going forward as well.
Frank's just raised an issue on the shortfalls, just to say that, you know, often either the patient knowingly or unknowingly knows they have one, and you put the bill in good faith. So often it's lack of knowledge that there's a problem when they book, or the appointment is the issue. I mean, you obviously don't get involved in that end, do you, at all?
Well, yeah, we want to. We absolutely want to, because, you know, if we can make the process fast enough that the bill can be presented and processed immediately, and you can tell immediately whether there's going to be a shortfall or an excess, then it can be captured immediately, and it should be captured in the same process. The whole thing could be automated. It's forgive my expression, a ball's ache at the moment. It's a slow manual process, and it doesn't need to be. So part of that is us working with the insurers to give us the information to say, is there an excess on this? Is there going to be a shortfall? And try and get that as fast as we can. And then part of it is to ease that collection process and modernise it. So, you know, I don't think we can make it a perfect world, but I think at the moment it's laborious, it's slow, it's inefficient, and I'm sure it leads to a lot of bad debt. It's interesting.
Just for example,
to
on your recent thing, I mean, did you know there'd be a 150 shortfall, for example? Was that an unexpected event? I mean, I don't know quite from the patient perspective whether these shortfalls are known or not.
I knew there would be a shortfall. I didn't know what it would be.
Yeah, yeah. So Frank, I mentioned that issue. Did you have anything else you wanted to mention on the fees, or was that answered satisfactorily? You're muted. Yeah.
Yeah, thank you. No, I think that's been answered satisfactorily. I mean, it is a very poor state of affairs, and has been for a great many years, where you have to chase shortfalls that you don't know about, and it just wastes a lot of secretarial time and doctor time. So, and
I'm just convinced
companies, they say they can't tell you that they can't give you that information because it's privileged.
Yeah, and I'm sure there's so much bad debt. I mean, I've got a colleague, a friend who runs a billing company, and he's just taken on, it's a physio practice, and he's got 4,000 unpaid invoices from that physio practice. 4,000. I mean, it's horrendous. And how much of that is there? And, you know, private medical consultants shouldn't be debt collectors. They don't need to be accountants, but the systems and support infrastructure around them is really bad. And it's not really been modernised in years. And, you know, okay, we may have a small part to play in that, but we need to try and do something about it. It's pretty appalling.
I mean, Frank chases every last £5, don't you, Frank? I think you... Well,
which there's a trade-off, isn't there, between how much time and effort you're going to expend, and moving on to the next. And I haven't found that balance yet, but I'm working on it.
There's quite interesting. What's the lowest level anyone's chased? I think there's a sort of a level of embarrassment when you're sort of going through those invoices. What's your cutoff, Frank? I mean, what do you say is acceptable? What do you write off?
Under £100, I very rarely chase.
That's very generous.
This is the problem, though. I mean, you're even talking about chasing. The system should do that for you. If you haven't paid an invoice, the system should remind the patient, remind the patient, remind the patient. You shouldn't have to do it manually. Now, this is where we're trying to get to. 21st century, you shouldn't be having to. I don't even know how you do it. Do you print it out in a letter and stick it in the post?
Well, that's a good question. Well, actually, I was interested in you talking about the practice software. So I use Midex Pro, and it's quite easy on that. You just press a couple of buttons, and it's whizzed off by email to the debtor.
Yeah.
So Jeffrey, just to say that you've seen massive changes, obviously, in your time. So I mean, what's your view of Healthcode's change in the market, and how does private practice reflected changes over recent years since they appeared? You're muted, Jeffrey, just sorry.
Sorry, yeah, well, it was very interesting, and thank you. I'm a senior citizen. I mean, the billing thing is complicated. For example, many people have an excess, and they may have used or spent 450 of their £500 excess. They get a bill for 200, they got to pay 50, the insurer's got to pay the rest. That becomes complicated. How are you going to manage things like that in a simple way for elderly people who may not be as computer literate as most?
I mean, we're not going to ever be able to manage it unless we can get the insurers to play ball. But I mean, to my mind, the way to do it is if we can get the hook into the insurers so we can know in advance, we can preload it, if you like. And that's the problem, is because the information follows, and it follows too slowly, and it's a chore to get it. The insurers know, but they only know at a point in time. And this idea that it's privileged is stupid. I mean, we need to challenge that.
It's all due down to competition between them. We saw at Finn that the hospitals, for example, would not give their details of the costs of self-pay. You remember that, Rosemary?
Well, it's going on at the moment, actually. Yeah. This argument just came up at the Finn meeting this week.
Yeah, so they won't give it away for commercial reasons. I can't see Bupa, PPP, etc. doing anything else. Now, WPA have done this in some respects because they are generally more generous than the others, but you run into trouble. There is competition law and all kinds of things. So I'm not sure how receptive the insurers will be. You've already indicated they're not very receptive to divulging all this information. The other question, of course, Mark, second question, is to do with employment, because there's a shift towards consultant employment, and that will affect everything. So I'll leave that first question with you about, divulging from the insurers.
So, Peter, I mean, you get the standard letters saying you've been compared to everybody else that they use as an endocrinologist, and you're much higher than everyone else. I mean, those seem to be the standard letters. So clearly, the insurers are monitoring all these fees much along the graph that you showed, aren't they? And using that as ammunition to try and drive the fees down.
Well, they only have their own data. They don't have any data from us other than their own. No, I think that this point about divulging the information, to be honest, really needs a strong argument back, because they have to divulge it. You can't do your job if they don't divulge it. It just gets divulged too late and in the event. And it's not an acceptable argument. It doesn't make any sense to me, because if there is going to be a shortfall, you've got to tell them what it is, but why do it 4 weeks later? Why not do it straight away? I mean, they do know, and they have to tell you. The only thing is the timing. That's important. But I think, we need to kick back on those fronts, to be honest. Because
Jeffrey's point about the salaried model, do you think that's going to change? Because that's obviously going to be working through. Do you think it's going to change how you operate anything or see?
I really don't know, because again, it's a bit like the OPCS CCSD coding thing. Forgive me for saying this, Jeffrey, but everybody's been talking about it for years and we've never seen much of it. I mean, I've been in one of the hospital groups 5 years ago, and they said that they were going to employ 30% of their consultants by 2020. I don't think they employ any. I mean, we've seen HCA employ a few. I mean, obviously you've got some of those organisations such as Shown that do, and Cleveland will, but we're not seeing any evidence of it in any great volumes. I know it's a discussion point, and I know it's a hot potato for the sector, but from what we've seen in it manifesting, we've seen very little of it, to be honest. You know, one of the things that we've always been made aware of is the indemnity problems, liability issues that are associated with salaried.
Yeah, that's the driver. The driver, one of the drivers anyway now, is the expensive indemnity for certain specialties.
And of course, and Jeffrey, just as you met, we had the MDU chief saying how some of these insurance policies ran out the moment you left the organisation. So this sort of long-term memory of your practice, it wasn't quite so secure as people realise. Rosemary, did you have any last comments to pick up?
Yeah, I just wanted Peter's opinion about something, a personal opinion. What do you think about this ADAPT programme and the amalgamation of Fin data with NHS data, and Fin's stated ambition and aim to use this to look at performance of consultants?
Fiona,
you've got 30 seconds, Peter.
I was going to bat it to Fiona.
Fiona.
The only thing I would say is it's a great aim. It's a loyal aim. Is it going to happen? I suspect not. Certainly not in the short term.
Okay, that sounds like a great place to leave it. I want to thank everyone for joining in and contributing, and a big thank you to Peter and Fiona for all their contribution and for all all the positives about Healthcode. I think we brought out, and I certainly feel a lot more positive about what their contribution is and their neutrality. And I think it's a major force for good in private practice. So thanks very much to you both, and thanks to everyone for contributing.